what is safe and what is achieved is nowadays discussed a lot. Thankfully, now the target is only one, that is LDL and LDL and LDL. Slowly, the concept of good cholesterol, HDL, and other aspects have withered away, and our singular target is LDL. The European Society of Cardiology in 2023 came in with the guidelines which were quite clear about the risk involved and the LDL levels to be achieved. Coupled with the guidelines by the Lipid Association of India, we can say that an average Indian adult at the age of 40 should have a LDL level of 100 milligrams per cent. Someone who has multiple risk factors should have levels of about 70 and less. Somebody who has documented ASCVD will have less than 55, and somebody with higher risk, that multiple risk factors, multiple ASCVDs, multiple interventions, and premature atherosclerosis would be as low as 30 milligrams per cent. In doing so, there has been no harm that is shown anywhere. In some of the trials like Fourier, the LDL levels were as low as 15 and no untoward effects were noticed thereof. In fact, every 40 milligrams per deciliter lowering of LDL leads to 21% reduction in atherosclerotic cardiovascular burden. So today, as in 2025, we must know that LDL needs to be lowered, strike hard and strike early. The total exposure of years of LDL also matters. So catch them early, strike hard, keep the LDL as low as possible. It started with lower is better, but now the motto is lowest is the best. Aim at the lowest possible LDL levels with the available means, and you will do a remarkable benefit for your atherosclerotic cardiovascular patients. Inclisiran is a new injectable lipid lowering therapy. It's been around for almost 5 years or more, and the track record has of thousands of patients over a period of number of years. It's a silencing RNA technique, and it works only inside the liver, not on the blood on the whole. The effects on LDL are dramatic, and it can lower almost up to 55 to 60% of the LDL from the baseline, even on top of a good statin therapy. So in order to achieve the LDL levels that we are looking at nowadays, inclisiran has a very major role to play. It's been approved by Indian DCGI in various aspects like the familial hyperlipidemia of the heterozygous variety or non-familial hyperlipidemia of mixed variety. It can be used in addition to known oral statin therapies if your LDL targets are not achieved. It's also approved in patients who are intolerant to statins, and they can be used alone or in combination with other things like bempedoic acid and ezetimibe. All in all, we have a very powerful agent which can lower the LDL levels to our desired levels. We foresee an increasing use of inclisiran in day-to-day management because there are a number of patients who don't achieve the LDL targets, especially of secondary prevention in our day-to-day practice. Inclisiran is indicated and is found to be useful in a number of patients. A classic patient would be where you have assigned a target of LDL, and despite the highest dose of statin, a bempedoic acid and ezetimibe combination, you are off the target. That's the time when you add inclisiran, you will reach the target definitely. Another variety is those who are statin intolerant at high doses. So you would have a combination of a moderate dose statin and other oral agents, and then add inclisiran on top of it. There could be patients who are totally statin intolerant, and inclisiran standalone can be used in these patients to bring the LDL levels as much as possible. So it can be used alone, it can be used in combination with statins, ezetimibe, and bempedoic acid as a background therapy. This is for secondary prevention, but for those who have familial hyperlipidemia of the heterozygous variety, it can be used for primarily reducing the LDL levels to safe havens, so about less than 130 or so. So I would say that familial hyperlipidemia heterozygous variety, mixed variety of hyperlipidemia with very high LDL levels more than 160 milligrams percent, and for secondary prevention in atherosclerotic cardiovascular disease. It comes as an addition to the baseline statin therapy, or it can come as a standalone for those who are statin intolerant. Inclisiran has now appeared in various national and international guidelines. The European Society and the American College of Cardiology have their guidelines, which finally boils down to adding an inclisiran when the oral dosing is not good enough or cannot be administered. But let's talk of the Cardiological Society of India guidelines for inclisiran. You have a patient of atherosclerotic cardiovascular disease for secondary prevention. If his LDL levels are achieved, then oral medication, then of course it's not indicated. If you have managed 40 milligrams of rosuvastatin or 80 milligrams of atorvastatin and you are still away from your target, add ezetimibe. After 4 weeks, if you repeat the levels and if you find that the LDL is still above 55, add a bempedoic acid to this orally. So now you have a situation, maximum dose of statin, ezetimibe and bempedoic acid on board for a period of 4 weeks. Still, if the levels are not achieved and 55 milligrams or below is not achieved, then inclisiran would be indicated at this stage. Addition of this on top of the onboard oral therapy would lead to greater reduction of LDL. So that is where we stand today. In guidelines, that is the role of inclisiran for secondary prevention in atherosclerotic cardiovascular disease. Inclisiran actually has been extensively studied and phase 3 trials are also over. The length of the studies are 18 months, but now the total exposure for inclisiran is more than many years. The Orion 9, 10, 11 were the trials which were used in familial heterozygous hyperlipidemias, atherosclerotic cardiovascular disease, or atherosclerotic cardiovascular disease equivalent. The study period was up to 18 months, and the standard dosing was used in all this. Efficiency-wise, a reduction of 50% of the LDL levels on top of the baseline therapy was achieved. The effect was up to 50% and sustained effect was maintained up to 50% at the end of 18 months. So we know that it is efficient and also it is sustained effect which is known with it. In all these trials, it was also realized the HDL tends to go up for whatever relevance it has. And also it is found that it is extremely safe without any side effects. If at all there are side effects, it are related to the injection sites, but systemically or otherwise, patient doesn't feel any side effects related to inclisiran. So good and robust data as of now to start off on inclisiran and see for ourselves as to how efficient it is and give the maximum benefit to our ASCVD patients. Inclisiran has been studied in various trials of the Orion-based, Orion 3, 9, 10, 11, and so on, including 18, which was in Asian patients. And the total patient years has been about 8,000. So about 6 to 7 years of follow-up of these patients is possible. One of the Orion trials was an extension of the all 4 original trials, and their extension has been for those who completed the trial, and the extension was given in the open label fashion. The efficiency related to LDL is maintained throughout this. Long-term safeties are very well proven because there are hardly any side effects other than the injection site. Inclisiran, interestingly, acts on the cytoplasm and not inside the nucleus of the hepatocyte. So the thought process of carcinogenicity or immunogenicity doesn't appear to be any threat at all. So on and on, I feel it's a safe drug even in long term, and one should embark on using of this as early as possible. As of now, hardcore outcome data related to inclisiran is not available. But if you look at the Mendelian survey of so many human population over a period of years, it is clear that long-term exposure to LDL-C is directly proportional to the vascular disease. So logically, anything that reduces LDL-C would result into long-term benefits or the outcome data. The Orion 4 and the 2P studies are ongoing for the outcome data of inclisiran, and in 2026 or 27, the outcome data should be available. The earlier studies were Orion studies that were conducted for 18 months showed a clear-cut reduction in about 21% reduction in cardiovascular MACE events as compared to placebo. It also led to less events as compared to placebo over a period of 18 months. So there is every suggestion that the outcome data would be favorable. The drug has been on board for nearly 6 years now, and we all very eagerly await the outcome data coming from these two trials. But logically thinking, it should result into good positive result, because anything that has reduced LDL has shown a benefit, whether it is statin, whether it is bempedoic acid, ezetimibe, or the combination of them.